Technology has helped us in many ways, even in the infection prevention. So infection control practices have come a long way. Like starting, if you look at the hand hygiene and in the present scenario, it has come a long way. But yes, there are many areas which need improvement. We have witnessed this during the COVID. We have seen the dedication work done by infection preventionists during the COVID. And now time has come when we need to give them their empowerment so that they can implement their practices. Now, infection control is evolving. Slowly it is, I can say, coming out or improving. People have started accepting it. The role of an infection prevention at the hospital level, national level, and international level, then surveillance, collecting the data and projecting your hospital acquired infections and in what way we can prevent it. And it is about the technology, how technology has influenced the infection control. Now from lab to the bedside. Previously, microbiologists were confined to the laboratory. They were like behind the scene, but now the scenario has changed wherein they go to the bedside, they take the rounds, they consult, they see the cases in the hospital, they give in their input regarding the antibiotic use or tracking any infection and how to prevent the cross transmission among the infection, among the patients. So this is how the entire scenario has changed. Now I have tried to put all the infection control practices in one slide. It's quite busy slide, but I will not go in detail about the each thing. It is the practices and policies which need to be followed by the every hospital, starting from the first picture. If you can see a doctor along with an engineering. So previously it used to be like construction of an hospital, inputs were taken from the engineer or the management, but now no, infection preventionist roles start even before the patient enters into the hospital. So we need to take the input from the infection preventionist to construct a hospital. So now I'll go in detail about each parameter. Now future, like it will be like electronic surveillance and reporting of healthcare associated infection. Then technology, in what way technology has helped in the infection prevention or infection control, emergency preparedness, and IT. Now you can see one of the picture. This is the picture which was taken during this week. Like we are conducting the symposium in our hospital and it is being viewed in the other hospital in a distant place. So you can see how the technology has helped everyone to communicate, in what way it has helped. So now coming to the construction. Engineering control, yes, it plays a major role, as I have already discussed. The role of infection preventionists start even before the patient enters or even before the building has been constructed. You need to take their inputs. Now, one thing is, every hospital will have a maintenance person or an engineering person who takes care of the construction. Now we do get blueprints like this where inputs are taken from the infection preventionist. They ask us, it's like very difficult. We always laugh, like what we are seeing, we don't understand all these blueprints, but we sit and go through the entire blueprints and we try to implement like where all the infection control practices, in what way it will help, be it a construction of a negative pressure room, positive pressure room, flow in a sense, patient flow, then biomedical waste flow, linen flow. So all this has to be seen before the construction. So coming to the negative pressure room, which is very essential, pandemic has taught us a very big lesson that every hospital need to have a separate, I'll say a separate building, so that in case in future there are any pandemics, this negative pressure room or a separate building will help a lot. So this is where the negative pressure rooms will help, and then all the infectious cases can be placed in those areas. Now, again, creating a temporary negative pressure rooms. So during the pandemic, many of us didn't have the, I'll say, the facility of the negative pressure rooms. In such situations, we can create the negative pressure or the isolation room. So in what way can we create? So we can place a curtain around the patient, okay, which will be totally sealed from the ground to the roof, and there will be a HEPA filter through which the air will be exhausted out into the environment. And then whenever there is a surge in the cases, whenever there are increase in the number of cases, so placing of infected patients is quite difficult. So to handle the surge capacity, we need to create an area. We need to create an area, or we need to create a ward in which we can place the infected patients. In our hospital, we have a separate, actually during the pandemic, we have created a separate isolation ICU where there were like see-through glasses were placed so that doctor or the nurse need not rush into the patient room every time. We used to monitor from the outside. Now coming to the hand hygiene, yes. So hand hygiene is very important. The first step which we teach every individual in our hospital when they join as an employee is the hand hygiene. So basic thing which will prevent the infection is hand hygiene. So one of the advancements is the touchless dispenser. We have this touchless dispensers in our hospital, wherein we use this and it becomes easy even for the doctors or those who are walking in the corridor, or the nurses, they use this. Now, to see is to believe. Only doing hand hygiene is not sufficient. We have to observe whether they are doing it correct or not, or we have to monitor them. In a sense, we have to monitor them. So how do we monitor? What are the advancements in monitoring? So this is the UV light. In the way after the hand hygiene, we see whether they have done all the 6 steps correctly or not. If they have not done the 6 steps correctly, we'll know in this UV gel or UV light. Now monitoring of the hand hygiene by using the ATPs. There are methods wherein we can monitor. This will give the immediate results, and we can teach them then and there whether they have done their hand hygiene properly or not. There are other methods like electronic hand hygiene compliance monitoring system. So where this is the real-time locating system for tracking the healthcare workers' hand hygiene events, while others offer video monitoring. There is something called as video monitoring of the hand hygiene. So there will be a sensors which are placed near the sinks or the hand rub dispensers, and it will capture and it will record whether the hand hygiene was done by the person who has passed through it, or it will give us beep, or it will give a reminders that you need to do the hand hygiene whenever you are passing through it. Now there is something called as radio frequency identification badges. So in what way this will help? So the person or the employee will have to wear this badges. So capturing will be according to the badge number. So it will identify an individual person whether they have done their hand hygiene or not. So in this way, the technology has improved, wherein the direct observation by an individual has transformed into an electronic observer through this radio frequency identification badges, wherein the individual employee will be monitored whether they have done hand hygiene or not. Now coming to your bundles. All of us know the bundles, the various bundles which we follow to prevent the hospital acquired infections. I'll not go in detail about the each bundle. What are the advancements which have come? One is the closed suctioning. Previously, it was like open suctioning. Now we have come with the closed suctioning, which will help to prevent the cross contamination, and it will also prevent the ventilator associated pneumonia. And then this compression devices, which will prevent the venous stasis. Deep vein thrombosis will be prevented. Now coming to the cuff pressure monitoring by the manometer. Why cuff pressure monitoring is important? So if cuff pressure monitoring is not maintained correctly, what will happen if there is an underinflation? There is a chances of aspiration. Whenever aspiration will happen and patient will get infected. Then if there is a over inflation, there will be a necrosis. So to prevent this, it has to be maintained at the correct, it has to be less than 20 centimeters of water. So it is measured by the manometer. Now coming to the central lines. All of us use central lines, and sometimes patients do end up with the central line associated bloodstream infections. Now technology has come to such a level where they have introduced the chlorhexidine patches. Chlorhexidine patches to prevent the infection. One thing I want to stress here, chlorhexidine patches, CDC recommends this chlorhexidine patches only when your CLBSI rates are high, in spite of using your basic infection control practices. So first you have to look into your basic infection control practices. In spite of that, if your CLBSI rates are high, then you can go ahead with your chlorhexidine patches. Then antibiotic impregnated catheters. The central venous catheters have come, which have been impregnated with the chlorhexidine or silver sulfadiazine or the minocycline or rifampicin impregnated catheters have come. Now these are the chlorhexidine impregnated patches and the antibiotic coated catheters, which will help to prevent the CLBSI where the rates of CLBSI are really high. Now coming to the safe injection practices. So needle stick injuries, it's as a whole, it is a topic which is very, I will say, in and out, like people do get needle stick injuries in the hospitals. To prevent, what has been done? So there are self-retractable syringes wherein after using it, it gets retracted, and there are safety devices which will prevent the needle stick injuries. This is how you can get down your needle stick injuries. Now, antimicrobial copper and silver coated surfaces. So these are the self-disinfecting antimicrobial surfaces which will prevent the infection. Now we also have this chlorhexidine gluconate bath and wipes for prevention of surgical site infections. Environmental cleaning. Now we are seeing the no-touch disinfection. There are various chemicals which have been introduced, like hydrogen peroxide. Then UV lights is one more thing which has come in a big way. Mercury vapor lamps, which can be used. So the touchless dispensing system, I have already discussed this with you. Previously, for cleaning and disinfection, we used to dilute the chemical using the measuring cup, and sometimes when measuring cup is not available, dilutions were like based on the assumptions or arbitrary. So now after that, there is a photograph here which displays the dilution of the antibiotics. Latest technology is the touchless dispensing system, wherein the sensors will be there and it will detect and it will start dispensing the chemical. Now, this is another way by which UV light is used, UVC. So this is like kind of robo, wherein you can operate with your remote. You can stand at the distance place. The moment you on it, it will enter into the room. And in this way, you can disinfect your room without entering into it. Now there are self-disinfecting surfaces, coating surfaces with heavy metals such as copper and silver, which I've already discussed. Then future, So in future, they might come out with a colorized disinfectant, wherein color fading matched to the disinfectant contact time. If you can see, there is a slowly fading of this from blue color to the white color, wherein you can see that the contact time has happened and the complete disinfection or the complete time has been given for the disinfection. These are the wipes. Increased visibility, in a way it will help, like whether all the areas have been colored for disinfection, whether all the areas have been covered or not. Now, how can we monitor it? So in the recent times, this technology has come wherein the fluorescent markers will be placed before the cleaning and the disinfection. Now, after the cleaning and disinfection has been done, we need to go back and check with the help of a UV light whether that area has been covered or not. Now, how clean is my ICU? I have discussed about this ATP in my previous slide, wherein it is used for like immediately it will give the result and immediately it will give the bioburden load. So this is the method by which we can detect immediately, like within 5 minutes you get the result and you can say whether the room or the disinfected area is done correctly or not. Now, discard of the liquid waste. Now, this is the biggest problem. Where to discard your liquid waste? There is a sewage room, then after discarding, how to clean it, how to disinfect the utensil. There is something called as absorb powder, which has come into the which has been developed, wherein if you place this powder in that liquid, it jellifies, it totally jellifies, and you can discard it. So the discarding of a liquid waste will not be a problem. Now, coming to this, in pandemic, we have seen in what way the N95 mask, which we used to prevent this infections. Major use was in tuberculosis, where labs used to use, and also in the TB cases where the doctors or the healthcare workers entering into the positive patient room, they used to wear this N95 mask. But during COVID, many of us have witnessed the N95 respirators. These are the N95 respirators which are fitted with the HEPA filters, like it will be useful. So in this way, the technology has advanced. Now, prevention of SSI, how can you monitor it? So in one way, in CSSD, yes, we do sterilize the instruments. There are various advancements wherein the load is released. One thing is you need to monitor your biological indicator. Biological indicator has to be passed and then the load is released. So there is a huge time gap from the time you have sterilized your machine to the release of your sterile sets. So the rapid incubators which have come into the market, which says that it will release the report in 4 hours from the time of run. Biological indicator results will be given in 4 hours or in 1 hour. So this is how we can improve our turnaround time. Next, coming to the disinfection. Previously, how the endoscopes were cleaned and how each and every part was cleaned with the manually with the use of brush. Nowadays, this is what is available is the endoscopic reprocessor. So it will help the manpower. It will help in increasing the efficiency in cleaning the scopes which are like hollow. So then next, coming to the diagnosis, molecular methods are helped in a huge way for the early diagnosis of the infections. So now one thing I would like to say, see, molecular methods is the future. In what way this has helped? Now, if you look into this, the blood cultures, previously this were done in the liquid media or the biphasic media. So every second day and fifth day, we used to culture it and then see manually we used to do, and we used to release the report. Then later on, it has come to a automated culture system, wherein we used to load the bottles. Machine used to read the bottle every half an hour and 1 hour, and then release the like say whether it is there is a positive culture bottle or not. But now advancement has come to such a level that we need not load it manually. We just need to place it on the platform, and the system itself will take it up, and all the negative bottles will, the system itself will release the negative culture bottles. So vaccines is one more area which needs a huge input or the investment. It will help in preventing the infection. Now, one thing which we recommend for the healthcare workers, see, this is for H1N1 or varicella, hepatitis B for all, then HIV and typhoid for your FNB. When it comes to varicella, we recommend for those workers who are taking care of immunocompromised patients. COVID vaccine, yes, this vaccine was given to all the healthcare workers. So vaccine is one more area where we can see and where we can improve a lot. Then next, coming to the antibiogram, all the microbiologists who are there who are listening to this presentation will agree to me. I am very bad at maths. Like if you give me, it will be a difficult process. So in the same way, doing your antibiogram, in the end of the year, we prepare the antibiograms, we release the antibiotic policy, sitting with the drug resistance, how many are resistant, how many are sensitive. It is a huge task. Previously, it used to take months together for us to prepare the antibiograms. But now, thanks to this WHO WHONet, which has made our life easier, we need to link the results with the WHONet, wherein the graph will be projected, which will display the resistance of each antibiotic, each organism, how the resistance is. So it has, the technology has improved to such a level. Now coming to the HI surveillance. Again, surveillance, yes, on day-to-day basis, all the infection control nurses go on rounds. They take the infections, they calculate the numerator, they calculate the denominator, how many of the patients have got infected. Now in our hospital, you can see the online tracking of the lines, like whether it is a urinary catheter or patient is on ventilator or is on central line. On day-to-day basis, we enter the data on the online, and this is at the end of the month, it will capture in total how many patients are there, how many central line days or catheter days are there, and then it will give you the data. Next, human microbiota. This is the one of the upcoming field, wherein it will help the individual who is suffering from certain kind of infection, wherein the like it will we can take the from the donor of known person or the relative, like brother, father, and then we can transfer the organism to the person. So next coming, infection preventionist role does not end in the hospital. So yesterday we have discussed something called as Apollo Kavach, wherein we have taken up the areas outside the hospitals, be the wherein patients were placed there. Those who are stable were placed in the rooms, and then infection control will go outside the hospital. It is like hospitality industry. Not only in the hospitality industry, even home care. Many of the patients were treated in the home, like through the online consultation. And long-term care facilities. There are long-term care facilities where the role of infection preventionist is the major. Now, what are the upgrades needed? So one thing which I would like to say is, every hospital or every every hospital needs a full-time infection preventionist. Okay, then in which way this will help? So you have to see to it that make it a rule. Amid of any ID threat, it is compulsory to use a mask. We should see to it that there is no supply chain failure. Infection control officer should be included in the emergency response team. You should see to it that there is an infection control person who will guide the team in a correct way. And vaccination, and then coming to the surveillance. Surveillance is one more thing wherein you need not hide your infections. Data has to be collected properly and show your infections. In this way, we can try and improve where all we can, in what way we can prevent the infections. Then epidemic preparedness. Epidemic preparedness, one thing. Yesterday, again, we have discussed about this epidemic preparedness in detail. So in what way accreditations have helped us? So all these accreditations, we always used to conduct the drills. So by the time when COVID came, many of our infection control practices were in place. So we could implement it immediately. And we should build our capacity of testing and build the capacity of the contact tracing. Technology changes. Last but not the least, which I would like to say is that technology change will be information system based, surveillance, clinical informatics, and surveillance. The emergency of these electronic surveillance systems depends heavily on the use of clinical data architecture. Okay, tracking of HIs, denominators, and numerators. This will make the life of an infection preventionist easy. So in future, maybe 30 to 40 years down the line, what will come up is the artificial intelligence. Artificial intelligence means it will take up the data from the each and every clinical point of view, and it will summarize in what way the patient can be prevented or what kind of infection the patient is suffering from. So in the end, I would like to say, having discussed so much about the technology, nothing can replace the human brain. Ultimately, it is the person or it is the infection preventionist who has to take the final word or who has to say the final word or the final decision. So in this way, I would like to say the career in the infection prevention as an infection preventionist is very bright. And infection prevention is the everyone's responsibility. If there is any failure or if there is any breach, if any person has infection or end up in a surgical site infection, you cannot blame one person saying that it is a failure of an infection control team. So think about it, and in this way, in what we can prevent the infection. So once again, I would stress it is the responsibility of every person, not an individual. Thank you. Any one of you have any questions, can please post in the chat box. No? Okay. I think this is the end of the session.
I would like to express my gratitude.
I am.
For Dr. Prathiba has talked about the future of infection. I'm very thankful to all of you and my sister and all of you on this session. I would like to make an announcement. I want to let you all know that the most anticipated International Safety Conference is going to be held on the 30th of February at Taj Palace in New Delhi. We are going to have eminent speakers chair the conference, and it is going to be a hell of a ride. We are going to have a short video game about the conference, and for more details, I request all of you to log into www.internationalpatientsafetyconference.co.in. Thank you.